So what we did is we created Measura. We used value-based healthcare, and we used Six Sigma techniques to come up with those critical elements that we could identify the problem, we could collect the data, analyze it, develop the solutions, and have a monitoring system that was relatively inexpensive and robust and reflected the actual change in the patient. So for example, if I have somebody that I'm measuring ApoE4 on for genetic marker for potential for Alzheimer's, I can measure that biomarker, and it's very valuable to measure. And it tells me if they're homozygous, they have a 95% chance of having a complication of Alzheimer's. And I can put them on a drug. It's an $85,000 drug. But the problem is that biomarker doesn't change, but other biomarkers do, and they do reflect what's going on. So I want to be able to have diagnosis, but I also want to be able to monitor effectively and cost effectively. And at the end of the day, have a much lower cost of care. What we really did was we developed an aggregation of tools that we can put into an AI system that makes it faster. We're not using something novel. I'm not going out there and inventing anything. What I did was I combined tools that already exist, that are well-defined, that already have appropriate coding, so there's no experimental stuff here. And we're putting it together in a way that's comprehensive and allows us to get to definitive diagnosis and treatment. So I'm going to go through the steps of what we're doing, and then I think it'll become clear. So what we do is we put a technician in your office, and that technician basically works at the front desk with you. And we pay for the technician, we pay for the training. It takes about 2 weeks of training to get them to the point where they can actually do appropriate review of systems and so take the intake of information. They actually will measure the height and weight. I find that most offices don't actually measure height. The average patient, between their stated height and their actual height, we've done this in our clinic, and I have 10,000 patients that we've looked at, 10,000 encounters over. The average difference is 1.5 inches roughly, it's 1.67 inches. That's a big deal. You're 1.5 inches off on these patients. And how are you going to calculate your BMI if you rely on the patient to say what their height is? So you got to take off their shoes and get them to actually measure their height. And most people don't do that. We're actually calculating the BMI, and the BMI for Asians for being obese is different than the BMI for Caucasians. And so we have to get to that. We actually measure their abdominal girth and standardize that measurement. If they're over 102 centimeters as a male, over 88 centimeters as a female, it's a problem. These are all accepted measures as in terms of metabolic syndrome diagnosis. And I'll be happy to send out this presentation to you guys. The one thing you'll find that's not on metabolic syndrome is LDL-C, and everybody talks about LDL-C. LDL-C has nothing to do with metabolic syndrome. Triglycerides and HDL do, but LDL-C doesn't mean anything. And so we look at those measures discreetly to get to a diagnosis. During that intake, the technician will try to elucidate very simple things like, is this patient overweight? Do they have pain? Do they have addiction or risk factor for opiate usage? If they hit any one of these points, they move to this second section. In general, 60% of the pediatric population qualifies, 93% of the general population, but 99% of the population seeking care qualify. We go through a quick review of systems. This takes 3.5 minutes. The whole process takes about 3.5 minutes. Based upon that, we go to standing orders. We sit down and they dump that data into the AI. The AI is in a laptop. It does not connect to the internet. We do not allow it to connect to the internet. In order to upgrade it, we have to physically get the laptop, put a chip in, and upgrade it. We've been working with this for about 9 months, and we elected not to allow it to have access. We take the same data that we're collecting and we put it in your EHR as well, your EMR as well. What we want to do is we want to make sure that our system doesn't directly connect. We're using a large language learning model that's pretty robust, but at the same time, it's pretty stupid. It's basically a filtering mechanism, but it allows it to use existing analytics of about 400,000 data points. And from studies that we've vetted, they're resident in there, and we use that to generate, hey, these are the list of valuable tools that might be beneficial. About 5 to 10% of the patients will need some form of significant genetic evaluation. It may be higher, depends on your population. But we're looking at things like, is the patient have risk for fatty liver? Are they at risk for Alzheimer's? Has anyone ever done a homocysteine on them? Should we do an ApoE4? Should we be looking at LPAR in this patient? Should we be looking at their omega-6 to 3 ratio? Should we be looking at their GGT? It goes through their list of medications. It produces a comprehensive panel that says these are the tests that would be valuable. Our technician then goes to whoever is your assigned physician that's covering in that area and says, hey, based upon our initial intake, these are the tests that we recommend. Is that okay or is that not okay? If it's okay, we draw the test and we send it out. We use about 5 different laboratory settings. They go to those labs. The analytics is done at those labs. We get all the information back within 4 weeks, and we schedule the patient for a series of testing. And these are the metabolic tests. Now, on stage 2, you don't make any money. On stage 1, you don't make any money. Stage 1 and 2 are done on the same day. Stage 3, that's where you make money, because that's where we're going to do the ANS, sudomotor, ABI, RQ, and vestibular balance. 60% of patients will qualify for vestibular balance. 95% to 97% will qualify for respiratory quotient. 99% will qualify for ANS and sudomotor, and a portion of those, probably like 96%, will qualify for ABI. The algorithm tells us what to do, and it takes the guesswork out of it from my staff, because we know what's defensible and what's not defensible. We don't want to overtest and we don't want to undertest. Why are we measuring RQ? We're measuring RQ because the formula that's used, which is a formula of BMI and heart rate, is inappropriate to determine basal metabolic rate, and you could be 40% off. Why are we doing ABI? Because you got to know what the arterial stiffness is, because you can modify it, and if you can modify it, you can change outcome. We're doing the same thing with autonomic nervous system. All of these things are based on hazard ratios. We generate a comprehensive score. The score is a percentage. So if you score 80% or higher, your chances of dying in the next 5 years, all-cause mortality, is less than 1 in 65,000. But you get down to a rate of, say, 50%, your all-cause mortality is going to go up to about 1 in 20,000. If you get down to 30%, your all-cause mortality is 1 in 5. So it's a logarithmic increase as the percentage goes down. If I retest you in 3 months and you've got a significant change, if it's gone up or down, it's valid, because this changes not minute to minute, but probably month to month. And if you've suddenly been able to change your arterial stiffness, let's say, for example, you have terrible arterial stiffness, and we put you, the recommendation is, hey, maybe you should consider some vitamin K2 and arginine as part of your lifestyle coaching program. That's going to change your arterial stiffness. In fact, there are well-documented studies that show that you can reduce the calcification in your coronary artery and your carotid by 9 to 11% within 12 weeks. And so there's very specific lifestyle decisions that you can make that are non-pharmaceutical. We can make those recommendations because we're going to be doing lifestyle coaching. So step 3 is the billability. We tell people that per interaction, this is about $450 globally generated. You're going to do 2.1 to 2.5 of these a year. Depending upon your location, this may be a lot more, but it's very rarely below 400.
Dr. Padda,
yes, sir.
is it a separate visit or is it part of the EM service?
You can do this as part of the E&M, because you're not doing a separate code for E&M. It's an ancillary service. There's no professional component to this.
Oh,
You can do this on the same day as another visit. You could do this literally at the same time. That's what most practices do. And what we do is we provide the service, we give you the report. It's about a 30-page report. And at that time, we're counseling the patient. So we're closing the loop. We're counseling the patient. You're continuing to do your professional service, whether you're doing an E&M service or whether you're doing some sort of procedural-based service, you're still doing what you're doing. This is ancillary service, so there's no...
You mean this is a separate bill. You'll be doing the separate, not part of that one.
Well, we're going to give you the bill. You're going to bill it, because what's going to happen is you bill it because this is a ancillary service done on your behalf. So that technician is in your office doing this service on your behalf, and you guys will submit the bill. Go ahead.
But LCD says you cannot bill with the EM services.
You can bill with it. You can't bill this as an E&M code, but you can simultaneously do this We do this all the time.
What is the specific code in this that you cannot build with the E&M service?
95923, 95921.
We bill it all the time.
Okay. That's okay, doctor.
No, that's fine. What we find is because it's a separately identifiable, because the E&M service for us is usually we're providing a separate service. Like, for example, we'll be doing medication refill and we'll be doing coaching.
Right.
And we'll be doing procedure, or we may not be doing procedure. If we're not,
If you do a procedure, you have to use a modifier 45.
Yeah, but this is the equivalent of doing like an EKG. That's how they view this, at least according to Medicare when we've dealt with them. I recognize that there are, like when we do UHC and Cigna, they don't have any issues with it. I do know that there are, like if you're doing the expanded, like if you're adding a G code to your visit, there can be a problem there. So if you're not doing G codes, you usually don't have a problem. I know that on Missouri Medicaid, because we have a separately identifiable service, that they've not given us any hassle. And we've done autonomic nervous system testing for 20 years. I may be completely wrong, but we have not had issues on 95923 or 95921, as long as the physician is not doing the autonomic nervous system testing. It's an ancillary service adjacent to the physician. But I mean, I definitely, you got to look at it. And if you find something different, once you've looked at it, tell me, because we may have been doing it wrong, and it's possible, but I mean,
What are the components of autonomic nervous system testing? Is it a QSAT and ABI and those PWV and those things?
Exactly. You're very familiar. These aren't novel codes. The only thing different is that system takes 40 minutes to an hour to do. And by the time that you get it all done, it takes time. What we've done is we've compressed it and we can get all of it done, including the RQ, in about 20 minutes. And then if we have...
bioimpedance testing is part of that too, or?
Yes. Yeah, we do a 4 blood pressure cuff impedance testing at the same time.
Okay.
We have Bluetooth.
Actually we did this like almost more than 5 years ago.
Yeah. No, this isn't new.
Yeah, there was a company, they put their tech in our office and doing all these things. And we were doing the VNG through a different company. We bought the equipment for VNG, and our MAs were trained to do the VNG, the bottom one.
Mm-hmm.
And the abnormal ones, we were sending them to ENT guys and vestibular rehab therapy and things like that.
Exactly.
Actually, for meaningful uses, we selected fall risk as one of the components. And whoever has fall risk, we were administering this test for them.
Yeah, it's about 60% is what we find.
Yeah.
What differentiates it is we don't do cold calorics. So what we're doing is we're using an ENG system. We still call it a VNG because that's the topical name for it.
Yes.
But we're not doing cold calorics. Cold calorics can be challenging and they take longer. And we're able to use a electroencephalography system, and we're able to measure the strabismus using electrodes on the face and use that system instead of putting anything in their ear. And
we're doing the same thing, the electrodes, yeah, not the...
And the biggest problem that I find with offices is that, it takes an hour and 20 minutes to do. When you add the VNG in, you're looking at an hour and 20. And so then you're looking at, was it really worth $450 for an hour and 20 minutes of time tying this up in my office? And it's probably not, in my mind. And what we're able to do is we're able to do about 3 of these tests to 4 of these tests, typically 3, in an hour globally, and get it done. Because we're...
Are you doing a DEXA scan for osteoporosis?
We are not. We usually will send that out. The DEXA scan does not have enough of a reimbursement. Now...
$25.
Yeah, it's not worth it.
It's not run.
I think that if I was running an orthobiologic practice by itself, I would get a CT scanner for a coronary artery calcium test. And at the same time, I would consider doing a slice through their liver and getting viscerogenic fat. And I would charge about $400 for that. And you would make good money at it. It's a low cost CT.
What is the test for visceral fat?
what you do is you can slice through a single slice through the
Oh,
liver.
the CT. Okay.
Yeah, you can do a CT or an MRI. The MRI obviously is more expensive, but you can get a portable MRI to do that. You only need 0.3 Tesla to do that. And on a CT scanner, you can use a low output CT scanner to get that done. I'm actually putting in that system at our new center that we're building. And we believe that, but it's an all cash system that's not insurance based, because nobody's going to pay you for a calcium coronary artery study.
Is it an angio CT?
I'm sorry?
Is it CT angio for calcium?
No, you don't have to do the angio. It's a straight up calcium study. What you're doing is you're using a background, you're measuring the calcium across the cut, and you're getting a percentage of that calcium. And then as long as you can come back to the same cut later on, you can do a comparison.
When they do the angio CT, actually you can see that calcium.
You can see the calcium.
Arteries.
But then it's
more relevant, the arterial lining, you see the calcium.
Yeah, no, but it's a more expensive test. And in order to get to that, you're gonna have to pre-certify that too. I'm not sure that, and I'm trying to pick tests that are individually less expensive and don't require a lot of hoops to jump through, but still get me the ultimate data point, and that are reimbursed by insurance. There is, if I was looking for gold standard, I would use the coronary artery calcium with an angiogram. That's
right.
the gold standard today, but it's not covered for the vast majority of patients unless you do it for research. And then I would use the viscerogenic fat in the liver with T2 weighted fat enhancement with single slice using an MRI, but that's not covered either. You can get something very similar though with a DEXA scan. You can use the thoracic component of the DEXA and do a weighted percentage visceral fat, and that's pretty accurate. It's probably within 3%, but again, that's not covered either. So I'm only picking the technologies that are accepted, I can get done quickly, and because Medicare doesn't have this as a time-based study. Medicare doesn't say, oh, you have to spend an hour doing this. Medicare says, we want the results. And as long as you've produced the results and the results are concordant and you do something with those results and you have an outcome that changes and you're able to monitor that and show an improvement, then it doesn't bother us. So this section 3 is where the revenue comes in. We still provide the technician, we provide all the equipment, we provide all the disposables, we do the testing, we produce the report, we hand you the report. You bill the report. When you get paid, 30 days later, you pay us. You don't pay us till you've already been paid. If you get a zero pay, you don't pay us at all. If you get paid, and then we're due 40%. And we set that number of the 40%. We don't say 40% in our contract. What we say is, look, we estimate it's gonna be $450. We'll know that when we do your first set of blood tests and your data collections. We don't get to this for 4 weeks later, so we'll have already collected 30 to 100 patients before this on all of their insurance. So we'll know what insurances are coming up, and we'll have monitored what we expect the results will be. And when we generate that contract in advance, it'll be a set rate. So you're only gonna pay us $140 for every exam, or you're only gonna pay us $120 per exam. And so we'll have set that. We can make an adjustment again.
No, did you say a percent of collections, or
we say
for each test?
for a percent of collections, how we do the calculation. But then what we do is we say, look, we're responsible for the pre-cert. If you don't get paid, you are under no obligation to pay us. So there's 0% collected.
So how many techs you provide? Is it
one technician per 1,000 patient that you have in your house.
1,000 patients per location?
Per location.
What happened by chance you took after 30 days, you get the 20% of the collections. Sometimes after 90 days, they will come and back take the money. So are you going to pay back the 20%?
We will, because we're obligated to, because that was our error. We don't want to hold your money. It is our error, and we will not hold on to that money.
Gurpreet, are all the payers paying for this, or any specific payers?
Almost every payer is paying for this, with the exception of the HMOs. HMOs we don't touch.
You don't even try to pre-cert with them?
We try, but if they don't agree up front, you can't hammer them. It's a waste of your time and my time.
But then you pre-cert anyway, so if the pre-cert doesn't go through, you don't do it anyways.
Yeah, exactly. We pre-cert every one of these. And so we already know what they're going to pay based upon their medical necessity. Remember, we're able to generate, once we've done that initial review of systems and we've got your laboratory testing, we're probably generating 3 to 5 additional diagnostic codes that you probably don't have. And we're able to provide those pieces of information to your insurer saying, hey, look, here's the patient history, here's their code set. This is what we believe is going on, and this is why we want to do this. And based upon the results of this, we're going to then make some changes for the patient and work with them.
What kind of changes you are going to make it? For example, patient got positive for the 95923 years, So what are you going to do the patient? What kind of treatment you are going to provide?
So it's dietary, it's lifestyle. 85% of all disease process in the US is probably lifestyle in some way or another. So what we do is we implement a metabolic health protocol for them. What we're trying to do is reverse their burden.
In your next presentation, next slides, like recommendations and things like that? Or?
Yeah, let me go on to the next one. So step 4 is you've got the results. Now you have a choice. You can have us do the lifestyle coaching, or you can do the lifestyle coaching. If you do the lifestyle coaching, then all of the money for step 4 with all the codes is yours. If you have us do it, what we'll do is we'll engage a company that does telemed. They will do 26 visits with the patient over the course of a year, doing lifestyle coaching based upon a written protocol. It's education and training for patient self-management by a qualified non-physician healthcare professional using a standardized curriculum. They can do it either telemed, which is what they can still do this telemed till 2026. There are other ways to do it as well. They can do a video conferencing, and they can even they can coordinate with you if you want to do group in your clinic. They typically will take 50% of the gross collected. You'll get 50% of the gross collected.
They take out of the collection.
They take it out of the collection.
That means we are billing or they are billing?
We are billing.
You're billing.
Yeah, they take it out of the collection.
Yeah. None of this is payment none of this is prepaid. Nobody's charging you anything until after you've collected. Our guarantee to you is, look, if you have to pay that money back because we screwed up, we're going to pay it back to you. If you get zero payment, you don't owe us anything. That's our problem. Our goal is to make sure that our patients that we're working with you on actually have a long-term change. And so our goal is to collect those data sets so that we can assist you in making those outcome changes. What we don't want to do is leave the patient with bills. And so we have some requirements of the laboratories that we work with. One of them is, look, you can't bill out of network. So we don't allow out of network billing at all. The second thing is there's no balance billing. They'll send one bill, but if the patient has financial hardship or says, I just can't afford it, then we don't want to have balance billing. We work with all these companies, and most of them have nonprofit arms that'll say, okay, look, if you can't afford it, we understand. Your doctor thought it was beneficial for you, but if you can't afford it, we're not going to chase you. We don't want the patient to be chased for these bills.
Yes.
That's why we set the rates relatively low. We know that it costs, to be transparent,